Dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Society of Medical University of Silesia in Katowice, I would like to thank you for coming and taking part in the International Medical Congress of Silesia 2024. My name is Aleksandra Nasiek, and it's my pleasure to coordinate the Oncology, Nuclear Medicine and Radiotherapy session. I would like to cordially welcome the esteemed jury, the president of the jury, Professor Bogna Drozdowska, and the members of the jury, Dr. Paweł Polanowski, and online Professor Iwona Gisterek-Grocholska.
Hello to all.
And Dr. Olgierd Hrabański.
Dzień dobry wszystkim. Dzień dobry.
We would like to explain you the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for the presentation is 7 minutes, and we have 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on to the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number on your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. All the presentation and the discussion must be run in English. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the Commission will ask the question in Polish, the authors of the work are obliged to answer it in English. We kindly ask the jury to assess scientific value, way of presenting, discussion, and own contribution to the work. When the session ends, we kindly ask you to give the cards back to the coordinator. To begin, I think we can start with the first presenter. And this is the clinical and laboratory prognostic factors in patients with mantle cell lymphoma, a single center analysis.
Good morning, dear listeners. My name is Jakub Kamiński, and today I would like to present you the results of our work entitled Clinical and Laboratory Prognostic Factors in Patients with Mantle Cell Lymphoma, a Single Center Analysis. Przełącznik. The aim of our work was detection of factors influencing 3-year survival of patients with MCL undergoing HASCT. And we set that goal for a reason. Nowadays, we do not have very accurate tools enabling us to precisely predict the survival time of patients with MCL. Mantle cell lymphoma has an uncertain prognosis, and survival times vary significantly between individual patients. Therefore, it is extremely important to conduct research on prognostic factors in patients with mantle cell lymphoma because it will allow us to more accurately predict the survival times of patients depending on their clinical condition and laboratory test results. Before I discuss the details of our work, let me briefly explain what mantle cell lymphoma is. It is a cancerous disease of the lymphatic system in which the precursors of cancer cells are B lymphocytes, which are located in mantle zone. But what mantle zone actually is? Now, let's look at the image of a healthy lymph node. There you can see a thin ring surrounding the germinal center, which is mantle zone. According to Starding 2016, it contains small mature B lymphocytes which are displaced from the germinal center by proliferating and differentiating B cells precursors in the germinal center. It is a rare disease. It stands only for 9.04% of lymphomas that are being diagnosed in Poland, and it occurs more frequently in men. Now, let me introduce you to our study. It is a retrospective study. It was based on the creation of database with informations and results from 103 patients of the Department of Hematology and Bone Marrow Transplantation of Medical University of Silesia. All patients had a diagnosis of mantle cell lymphoma. A number of factors affecting 3-year survival were analyzed. All patients underwent autologous bone marrow stem cell transplantation. The figures are from the period from 2007 to 2021, and Statistica software was used to perform statistical analysis. As for the sample group, the age of lymphoma diagnosis ranged from 42 to 70, with the median age of 59. 36% were women and 64% were men. The vast majority of patients, as almost 70%, at the time of diagnosis showed stage 4 in Ann Arbor classification. The average time from diagnosis to the autologous stem cell transplantation was 14 months. All factors examined were analyzed in terms of 3-year survival. So I would like to highlight on this slide how many of patients actually survived the 3-year period, and it was 72.8% of patients. On this slide, I would like to highlight MIPI index, which is a prognostic indicator used in mantle cell lymphoma that is calculated at the time of diagnosis. The slide shows what is necessary to calculate it. In our study, we have shown that 3-year survival was statistically significantly dependent on the height of MIPI. Patients with higher index, indicating a worse prognosis, showed lower 3-year survival. Another factor we have examined was the level of serum lactate dehydrogenase. Greater 3-year survival was statistically significantly associated with the lower levels of the enzyme in the blood. In the graph, we can compare the median and the range of the levels of serum LDH in patients who did not survive 3 years versus those who survived 3 years. Another factor important to patient survival appeared to be the level of the disease remission before autologous stem cell transplantation. Patients who achieved complete disease remission before autologous stem cell transplantation were more likely to survive 3 years than those who achieved only partial disease remission. We also examined factors such as age, gender, degree in Ann Arbor classification, and ECOG score. And none of them showed statistically significant relationship to 3-year survival. The box plot on the right side of the slide, however, shows us some trends related to the age of patients, in which we can see that 3-year survival was lower in older patients. But it is important to note that treatment in mantle cell lymphoma is very intensive, tolerated less by older patients. But on the other hand, the unfavorable gene profile may reduce life expectancy of younger patients. Another extremely interesting fact is that patients whose white blood cell system regenerated more quickly were more likely to survive 3 years. And this regeneration is expressed as the number of days after autologous stem cell transplantation, after which white blood cell value reached at least 1,000 per microliter in the blood. In contrast, there was no such relationship observed in relation to the rate of platelet regeneration. Moving on to the summary. Promising prognostic factors are LDH serum level, MIPI index, remission status before ASCT, and the rate of regeneration of bone marrow after autologous stem cell transplantation. In our study, we have shown that above-mentioned variables have statistically significant impact on the 3-year survival of patients with mantle cell lymphoma. However, further research is extremely important, especially due to the uncertain prognosis and hard to predict effects of the disease. And that is all I wanted to present to you today. Thank you very much for your attention and for listening, and I am inviting you to the discussion. I'll do my best to answer any questions.
Thank you very much for your presentations, and I think we can start the discussion. Are there any questions?
Yes, I have a question. The first patient from this study start his treatment at 2007. It is about 20 years ago. How the treatment changed from the 2007 to 2021. It is a monolith group of treatment, of there are a change of treatment because the type of treatment, in my opinion, is not prognostic, but depend of prognosis. Thank you.
Yeah, of course, the treatment changed, but in our database, we have taken under our consideration a few methods of chemotherapy that were used, and we were trying, such as beam, and we are trying to stick to the concrete groups of chemotherapy in patients, and we have taken it under our consideration while we in the database, I would say. We are sticking a few methods of chemotherapy used in patients. And as I said, every patient had undergone autologous stem cell transplantation.
Thank you very much.
Thank you for a nice presentation. Two questions. One, what is new of your study comparing to our data?
Could you repeat?
What is new? What is new comparing with the world data?
The new thing, especially, is the rate of regeneration of bone marrow. I mean, the indicator of rate of white blood cell regeneration. Of course, MIPI is like kind of old prognostic factor, but the rate of regeneration of white blood cells is something new. Mm-hmm. It is maybe in only a few studies about MCL, and it is not commonly used. So definitely, especially this one factor is totally new.
Okay, and the second question, short. You presented 3-year survivor, what not 5?
It's because we also had a patients from 2021, and it's hard to say about 5-year survival because it will be in the 2027. So that's because that was our longest observation of patients from 2021.
And so one question from me, what was your contribution in this project?
I would say that it was 100%. We've done also statistics all by ourselves using human Whitney and chi-square test in Statistica software. And also we were manually reading all the documentations of all the patients. But of course, we were inspired to make a study about MCL by our tutor, and we've got precious advices, and our work was reviewed by our tutor. But I do believe that our contribution was 100%. Thank you very much.
Thank you very much for your work. And I think we can move on to the next presentation, which is how reliable are safe and AI-generated information for laryngeal cancer, a comparative analysis of LLMS.
So good afternoon, everyone. My name is Anita Sisley Joseph. I'm a 5th-year medical student in Collegium Medicum in Bydgoszcz. And today I'll be presenting our study on how reliable and safe are AI-generated information through large language models. So I'm sure that most of us here use Google on a daily basis, right? So I'm sure that we've all had some point in our life where we've searched up our own symptoms online, or we even know people or friends who have searched up their symptoms online as well. And instead of feeling reassured, we're often left with we go down a rabbit hole of worst case scenarios and end up with a list of terrifying diagnoses that Google gives us. And it either tells us that it's life-threatening or that we need to go see a doctor as soon as possible. Oh. Okay. So In a study conducted on the Polish population, nearly 80% of the participants said that they turned to the internet for their health-related questions. Next slide. And nowadays, with so much health information that's available online, it's kind of hard to tell what is reliable, and especially with the rise of new technology like these AI-based large language models. And since laryngeal cancer is one of the most prevalent head and neck cancers, we assessed these questions through these 3 LLMs. So next slide. On ChatGPT 3.5, GPT 4.0, and Google Bard. And we assessed how reliable and safe the questions that people seeking information on laryngeal cancer might be through search technologies. For our study, we developed 36 questions that individuals directly or indirectly affected by laryngeal cancer may ask these large language models themselves. And we divided them into the following categories: of diagnosis, which had 11 questions that we asked the language models, and then treatment, which had 9, and then novelties and upcoming treatment, controversies, and sources of information. Yeah. And then 3 groups evaluated these responses. And the first group was Group A, which were the experts or the professionals in the field of head and neck oncology. And then Group B were doctors or junior doctors who were non-specialists in ENT. And the next group was the non-medical professionals. So these are in the general medical population who have no professional knowledge in medicine. And altogether, they evaluated 1,620 responses and rated them. And for rating them, we decided to split it into quality and safety. So to assess quality, we used the global quality score, where 1 represents poor quality and not at all useful for patients, and 5 equates to excellent quality and very useful for patients. And as for safety, we used a 3-point system, where the first point is for unsafe or misleading information, 2 is safe information but not entirely accurate, and 3 is safe and fully accurate. So what scores did the reviewers give for the safety and quality of these large language models? So as you can see at the top in green is the highest score you could give for the safety of the responses. And for the experts on the left side, for GPT 3.5, 70.80% of the GPT 3.5's answers received a score of 3 from the experts, placing it as the safest amongst the 3 language models. And only 50% of Bard's responses received a score of 3, placing it as the least safest amongst them. And as for the doctors, you can see that their analysis concluded with more percentage of the answers getting a high score of 3, but it remained consistent in terms of GPT being the safest and Bard being the least safest. And as for the quality, we also see that GPT 3.5 still got the highest scores for quality compared to GPT 4.0 and Bard. And although 5 is the highest score you could possibly give for quality, you can see the experts gave majority of the responses across 3 models a score of 4, and while doctors gave a majority a max score of 5. Regardless, it's clear from the graphs that GPT 3.5 and 4.0 still scored better in quality than Bard. And we also, this graph is to show the average safety scoring as well. And you can see the non-medical professionals, they gave their highest average safety score of 2.63 in purple at the very bottom for Bard, which is completely opposite of what the other groups were grading it. And the lowest score that they gave was for GPT 4.0 with only 2.44 as the average safety score, making it the least safe according to the non-medical professionals. And then the average quality scores, GPT 3.5 got the highest average quality score by the non-medical professionals of 3.99, and the least was for GPT 4.0, which is 3.05, which is the lowest even amongst the other groups that graded them. The non-medical professionals gave the GPT 4.0 the lowest score. Yeah. So this graph shows the distribution of the word count across all three models for the responses we received from the three models. And the highest word count in total was for BARD, where it was 12,184 words in total. And then it was followed by GPT 3.5. And lastly, GPT 4.0 only got 7,130 words in total was produced by it. So we examined if there was any relation between, the length of the responses and the ratings that they may have given. We wanted to find out if more information meant that people perceived the quality and safety as, better or less better. And we found that group A and B, there was no significant correlation, whereas group C, so the non-medical professionals, found that there was a moderate, strong correlation, which kind of goes to show that maybe people who are not familiar with the medical field might find lengthier explanations because it might give them a better understanding. And another noteworthy thing to point out is that how up-to-date these language models are. So while we were doing our research, we found that it was only updated until September of 2021. And as of last Sunday, GPT 3.5 said that they have their information updated until January 2022. So is it really safe and reliable? For laryngeal cancer-related questions, symptoms and diagnostics, especially professionals and doctors deemed it very safe and reliable, whereas even non-medical professionals deemed it trustworthy and credible. However, it is important to note that other medical conditions have to be addressed differently because we have no information on it. Like our study is only focused on laryngeal cancer, so it may vary for other fields and other topics for medical conditions. And therefore, although large language models are resourceful for patient education, professional oversight should accompany it. And that's all. Do you have any questions?
Thank you very much for your presentation. And we can start the discussion.
Thank you for a nice presentation. I have one question. Do you think if it's possible to replace conversation with doctor by AI system, or is it only support the doctors?
I think it's going to be a very difficult thing to do, because I'm sure we've all talked to these AI models ourselves, and you can tell that there is that lack of emotional connection that you would have with a human being. And think about it, you're being a doctor, you have to see a patient, you have to have empathy when you're going to talk to them. So I don't think you could fully replace it. That's why it could be a great addition for patient education rather than completely replacing a doctor.
Yeah, thank you very much.
If I can, I have a few questions.
Okay.
First question is about the group of the experts.
Okay.
In the presentation, you show us that there are professors.
Mm-hmm.
How many? How big was this group? And if it is comparable with group of patients, that's my second question. What was the age of this patient, and what the patient was treatment of which cancer or other disease?
Okay, so the first question. So it is one of our limitations, the size of the evaluators. So for the professionals or the experts group A, there was only 3, but it was 3 across all 3 groups. So it was 3 experts, 3 junior doctors, and 3 so-called non-medical professionals or patients as well.
Yes, so these groups are only 3 persons in each group.
Yes,
Okay.
it is a limitation, yes, definitely.
Yes, it was a great limitations.
Yeah.
And I think that the opinion of 3 experts are 3 opinions.
Yes,
Only.
it is. Yes.
Only, and patients, about patients, what the patient was
So the patients aren't actually patients. These were like the non-medical professionals who, our inclusion criteria for these people were that they speak English and that they are not in any way related to the medical field, so that we could somewhat simulate a patient kind of situation.
So the patient was speaking English.
Yes.
And what disease they have?
They
are
don't.
treatment of laryngeal cancer.
Sorry?
They are treated of laryngeal cancer or other disease.
Well, in our research, we weren't looking for particularly any diseases that they were having. Our questions were based on, when we were making the questions, it was based on very basic questions that anyone who might be affected by laryngeal cancer may ask. And those were what we kind of tried to simulate. And the people assessing it didn't necessarily have the disease, but were maybe, we were just trying to simulate the sense of, it's someone who doesn't have any idea about laryngeal cancer. So they're kind of reading information that they are not aware of. But if they feel like, it gave them the right information and they felt like, they were able to regain knowledge from it for the disease, that's how they rated it then.
Thank you very much.
Thank you.
Okay, thank you very much for your presentation. And I think we can move to the next one, who is the typical colon cancer patient. Esteemed jury, ladies and gentlemen, my name is Aleksandra Korus, and I would like to present our work entitled Who is the Typical Colon Cancer Patient? As the title says, we are going to present the typical profile of a patient operated on for colon cancer. But first, let's talk about the disease. It's one of the most prevalent cancers in men and women. It ranks third after the lung and the breast in women, and the fourth after the prostate, lung, and skin in men. The treatment consists of chemotherapy, different regimens using 5-fluorouracil, capecitabine, irinotecan, and oxaliplatin, radiotherapy, especially in the cancers situated in the rectum, and targeted therapy. We can't forget about surgical interventions, for example, hemicolectomy or anterior resection, depending on the localization of the tumor. Let's talk about incidence. Colon cancer constitutes 12% of all cancers in men and 10% in women. This is data for Poland. In Europe, it is the cancer of even higher incidence, almost 14 of all cases. And standardized mortality rate for Poland is 13 over 10,000 for men and 7 over 10,000 in women. In our study, we analyzed the basic clinical data of 84 patients operated on for colon cancer in the Silesian region in the years 2017 to 2019. Collected data included age, BMI, classification of the tumor, and some chosen blood count tests: hemoglobin, white blood count, neutrophils, and platelets. Let's move on to age of our patients. Our youngest patient was 41 and the oldest was 85. As you can see here, most patients were aged 60 to 69 and the mean age was 66. Mean BMI was 27 for women and 26 for men. It is above the normal range. As you can see, there were more obese women. The pink graph is for women and the blue graph is for men. And men tended to be more overweight. I would like to introduce you to the Asler-Colle classification that is used specifically for colon cancer. There are 4 letters and 3 numbers. A means limited to mucosa. B means invasion into different layers of the intestine. C means lymph node involvement, and D means distant metastasis. And 1, 2, and 3. 1, 2, and 3 means different infiltrations. When it comes to the classification of the tumors, 30% of them were at grade 3. That means no distant metastases. And the most prevalent TNM classification was T3, over 50%, N0, 54%, and M0, 86%. So over 3/4 of the patients had this classification. And the most common Asler-Colle classification was C1, followed by C2. When it comes to the blood tests, most patients, 54% of patients suffered from anemia, and it was mild anemia. Mean hemoglobin was 12.15. And this is the graph for women. As you can see, more women had normal hemoglobin and more men had anemia. Leukocytosis was present in 23% of the patients. Leukopenia was diagnosed in 2 patients. We assume that this is because of the inflammation going on because of the cancer. Neutrocytosis was observed in 18 patients, and none of the patients suffered from neutropenia. It's important to notice that we did not have data on chemotherapy of these patients. And the platelet count was 316, and it is within the normal range. Moving on to the conclusion, a population most operated on for colon cancer were women. However, the difference was slight. There was a difference of 2 patients between the group of men and the group of women. Most prevalent age was 66 years old, typically a bit overweight with slight anemia. Blood count tests were inconclusive with the exception of leukocytes. I would like to say here that this is nothing out of the ordinary. And we see patients like this everywhere, even on the street. So this is why screening is important, because the mean age was 66, which is within the age of colonoscopies in Poland. Thank you. And
Thank you very much.
Questions.
Thank you very much. Are there any questions?
Before a question, one remark. Colon cancer. Your study concerns not colon cancer, but colon carcinoma, because cancer means malignant neoplasm. So in colon, the most common is carcinoma, and your study concerns colon carcinoma. So this is all my remark. When you will publish or present the study, please remember. A question is, so we know there are many publications concerning colon carcinoma. What is new in your study?
We are focusing on surgery. So probably the thing that we read the most about was prognosis, depending on the classification of the tumors and different types of classifying the tumors.
Okay.
Okay, and I have one question. What about biochemical markers like CA19-9 or CEA?
We had some data on CEA, but it wasn't complete in all patients, so we decided to exclude it from the study.
But you take it into account, yeah? You analyze it?
We were, but it was available only in about half of the patients, so it wasn't conclusive.
Okay, thank you.
Thank you very much. Are there any other questions? Okay, so we can move to the next presentation. Thank you very much. And the next presentation is evaluation of multiple models predicting the results of hybrid imaging in primary hyperthyroidism.
Good afternoon, dear jury attendees. In my presentation, I will focus on machine learning models predicting the result of preoperative scintigraphy in primary hyperparathyroidism. In PHP, which is relatively common endocrinopathy, key findings come from biochemical tests assessing calcium and phosphate metabolism, and about 85% of cases are caused by a single enlarged gland containing an adenoma. Hence, the treatment of choice in most cases is parathyroidectomy. So, the question if preoperative imaging in PHP is beneficial to patients suggests itself. An American radiologist, John Dorfman, coined the saying that the only localization study you need is to locate a good endocrine surgeon. Well, there is a lot of truth to this statement, especially if imaging fails to visualize the lesion. But when we do localize the adenoma, we can do the procedure with an incision even smaller than 2 centimeters laparoscopically, and we can avoid bilateral neck exploration, which translates into shorter duration of the surgery and lower risk of complications, including mortality. To achieve this, ultrasound and single photon emission computed tomography combined with scintigraphy are the most common imaging modalities, with the latter one being more sensitive. Unfortunately, some adenomas exhibit the uptake of the radiotracer, which is insufficient to visualize the lesion, and moreover, hybrid imaging is associated with higher exposure to ionizing radiation. So the ability to predict which individuals are unlikely to benefit from imaging would allow us to abstain from this imaging modality and avoid the risk and the waste of resources. To achieve this, we've developed and evaluated 4 advanced predictive models: logistic regression, classification and regression trees, random forest, and XGBoost classification trees. All of them were constructed using retrospective clinical data obtained from nearly 500 patients diagnosed with PHP who underwent hybrid imaging between 2010 and 2022 at the Nuclear Medicine Unit in University Hospital in Krakow. We assessed the global importance of all included variables by means of Shapley importance measure. The positive imaging subset consisted of 234 patients, whereas the negative imaging one comprised 265 patients. So the positive result was in about 47% of patients. That's definitely less than we would like to see. The positive imaging group was characterized by higher prevalence of urolithiasis and higher maximal lesion diameter and lesion volume measured in ultrasound, which is consistent with previous findings. Moreover, parat hormone, total calcium, alkalic phosphatase were higher in those with positive imaging, whereas inorganic phosphates and vitamin D serum concentrations were lower in those patients. Parat hormone, maximal diameter of the lesion in ultrasound, and total calcium emerge as top three most important variables in all models. Vitamin D and inorganic phosphates were also significant in the prediction. Regarding out-of-sample performance of all considered models, the good old logistic regression performed best in terms of accuracy, which was about 70%, in terms of specificity, which was about 81%, and we value this parameter best in this case, and the area under curve was also the highest, reaching about 73%. Random forest model was characterized by the highest sensitivity, reaching about 63%. Although the CAD model did not perform as good as the aforementioned ones, it is still easily implementable and it can provide several easy-to-use in the clinical setting rules. For example, patients with parat hormone over 180 picograms per milliliter had an 80% probability of positive scintigraphy, whereas those with parat hormone below 115 and maximal lesion diameter below 0.81 centimeters had the probability of negative scintigraphy reaching 71%. And to conclude, before offering preoperative scintigraphy to patients with primary hyperparathyroidism, attention should be paid to biochemical parameters because they emerge as significant predictors of the result of the hybrid imaging. And in our study, logistic regression and random forest demonstrated superior performance in terms of sensitivity and specificity, but they require development of a software which is user-friendly and can be implemented in the clinical setting. But CART could also aid decision-making and provide some rules which will be easy to implement for now. Thank you for your attention.
Thank you very much for your presentation. And we can move to the discussion. Are there any questions?
What is your own contribution to this work?
I was responsible for the conception of the study. I've done over half of the database and do at least the simple statistic because in terms of machine learning, we've got support from our tutor.
Okay, and now I want to say that I believe that my colleague from jury, Dr. Hrabański, has a question.
Okay, so I would like to ask you, did all these patients who are in the DBase go for operation?
Unfortunately, we've got some loss to follow up. And moreover, we are aware of the limitation that we don't have access to all of the histopathological data because a lion's share of the patients was referred to other hospitals in Krakow or also even in other centers. So we couldn't verify if what type of lesions were there actually and what was the histopathological characteristics of the adenomas found.
Okay, so you don't have really this follow-up and you really don't know it was parathyroid or no? You base only or for the result of parathyroid scan?
We've decided that even if we have this limitation, we would like to do a real-life study. So we've just picked all of the patients that were referred to it, which was in the reality.
Okay, but this is for us together now clearly that we really don't know it was really a positive scan or negative because only way to confirm it is operation and next confirmed by pathomorphologist.
Yes, I agree with you that we don't have this 100% confirmation, but it is done this way in the clinical setting. So we think that this conclusion is useful as well.
Okay, my next question, in one of the table you have ultrasound diameter of the lesions. All of the lesions have been proved by ultrasound?
Not all of them, but over 50%.
Okay, so this is next that we have the diameter only for 50 or 60%. Okay, because I of course highlight your work, and it's 400 people, it's a lot, but as I said, we don't have really confirmation, and also the predict factor, what you say, so PHT and calcium level are well known, that we should only refer the patient who are with the calcium elevate and PHT elevate. For example, in the United States, in some guidelines, they say that it should be highly elevate, about 160, because it's, as you say, the high exposed for the radiation. Okay, so nothing from me, but it's nothing novel in the results of exam.
We've provided useful thresholds for Polish population, and we think that nevertheless we can gain something from it.
I think it will be very good work after follow up this patient, because in one of the first of the table of the slideshow, you said and highlight that of course we have some false negative, because you use the protocol of using one isotope or two isotopes.
To my knowledge, it was one isotope. But the course of time was very long, and even the nuclear unit was transferred to a new center, so I can't say this with 100% sure.
Okay, because when we comparable the method, the best methods still are subtraction with technician and technician with MIBI. When you do it, you avoid a lot of false positive scan, and you use only one isotope. So as you highlight, when you have the retention of the radiotracer in delayed phase, it can be parathyroid adenoma, but also can be the thyroid adenoma. Nothing to add, no question more. Thank you very much.
Thank you.
Thank you very much for your presentation. And let's move to the next one, sleep CRAP criteria as risk factors for neuropathy in bortezomib therapy, retrospective analysis.
Morning. My name is Daniel Hebraszka, and today I will be presenting the results of my study, SLIM CRAP criteria as risk factors for neuropathy in bortezomib therapy, a retrospective analysis. So to start, we will be talking about treatment with bortezomib, and we'll be focusing on patients with multiple myelomas. It's the most common indication for this drug. And multiple myeloma itself is well known. It's one of the most common hematologic malignancies, proliferation of abnormal plasmocytes with a wide range of symptoms and forms. But we'll be focusing on patients who were treated with bortezomib. So there are mostly patients who are eligible for autologous hematopoietic stem cell transplantation. So the point of the bortezomib is induction therapy, in which we hoped to gain remission, after which we could consolidate further with autologous hematopoietic stem transplantation and then continue with the treatment depending on a case. Bortezomib itself is a proteasome inhibitor, and has a high risk of causing peripheral polyneuropathy during the treatment. It's about 30 to 50% patients, all patients treated with this drug, who will eventually develop the neuropathy. The known risk factor is if patient already has some form of neuropathy, therefore it is very likely that the treatment will exacerbate that neuropathy, but other risk factors are not well established, and previous studies gave conflicting results as to it. The SLIMCRAP criteria themselves are criteria assessed before the beginning of treatment. They give us insight into how much damage did the multiple myeloma did to the patient's body, how much there are signs of organ damage essentially. So we assess them to see how much patient, how sick the patient is, how much he needs treatment, and then we can also monitor if our treatment is successful. For the aim of the study, we studied to assess whether those SLIMCRAP criteria can also be used as potential risk factors for development of peripheral neuropathy in patients who received bortezomib in this first-line treatment of multiple myeloma. I performed a retrospective analysis of patients treated at the Department of Hematology and Bone Marrow Transplantation in Katowice in year 2020. We've included cases of patients who were in age up to 70 at the moment of diagnosis, as they were most likely to receive bortezomib. They must have been diagnosed with multiple myeloma in year 2020. The first-line treatment must have included bortezomib and of multiple myeloma, and patients couldn't have been treated for any hematological malignancy before. We've evaluated the correlation between presence of SLIMCRAP criteria at diagnosis and development of peripheral neuropathy at any point of treatment, with exception of M criterion, because it requires a whole body MRI scan, which is not routinely performed in our country in this indication. And we've analyzed the data using statistical program. So in total, we had 59 patients included in the study, 36 males, 23 females, with a median age of 63, ages ranging from 36 to 70 years old, and peripheral neuropathy eventually developed in 23, that is 39% of those patients. And for the results, the S criterion, that is at least 60% infiltration of bone marrow with plasma cells, was found not to be of statistical significance for development of neuropathy at any point of treatment. Similarly, the Lee criterion, that is a ratio of involved to uninvolved free light chains in blood serum, was not found to be of statistical significance for the development of peripheral neuropathy during the treatment. The C criterion, a serum calcium concentration above 2.75 millimoles per liter, was found not to be associated with the development of peripheral neuropathy during treatment. The R criterion, that is kidney damage serum creatinine concentration of over 177 micromoles per liter, present in 25% of all patients, was not found to be associated with development of peripheral neuropathy at any point of treatment. The A criterion, anemia, whether we have taken a definition of hemoglobin level less than 10 grams per deciliter or 2 grams per deciliter lower than lower value of norm, there was no association between presence of this criterion and development of peripheral neuropathy. And the final B criterion, similarly, there was no association between the fulfillment of this criterion in a patient and further development of peripheral neuropathy during treatment. So in conclusion, this retrospective study failed to prove that SLIMCRAP criteria could be useful as risk factors for development of peripheral neuropathy in multiple myeloma treated with bortezomib. Thank you very much. If you'd like to ask me any questions, I'll try to answer.
Thank you for your work. We can start the discussion now.
Only one short question. Is this drug bortezomib is a new drug in therapy of multiple myeloma?
It's used for, I think, some 10 to 20 years. So it's not very new drug. It's
not
certainly
new. So new is information about neuropathy. This is new. The information from the study neuropathy concerning this therapy is new, or there are publications about it?
We know that bortezomib causes neuropathy, and there's a lot of publications on it. There was never checked whether there is association with the common prognostic factors that are routinely assessed at the beginning of treatment. So we've tried to see whether they may be helpful. It looks like they are not, but this was a small group, so we may see in the future.
Thank you very much. Are there any other questions, maybe? If not, we can move to the next work. Thank you very much.
Thank you.
Okay, so is there a difference between right and left-sided colon cancers?
Dear committee members, ladies and gentlemen, my name is Michał Serafin, and I'm here today to present our study about the differences between right and left-sided colon cancers. Let's begin. Colorectal cancer is the third most common diagnosed cancer in Poland. Globally, it constitutes of 50% of all cancers, with approximately 1.4 million new cases reported annually. Its incidence is especially high in high-income countries such as Sweden or United Kingdom. In addition, recent studies suggest that younger and younger population is being affected with colorectal cancer every year, posing a growing problem for public health. From clinical pathological perspective, colorectal cancer should be divided into three different entities: right colon cancer, left colon cancer, and rectal cancer. There are several differences that support this division. Firstly, right side of the colon and left side of the colon with rectum develop two different embryological guts. Right side of the colon from midgut, while left side of the colon and rectum from hindgut. Secondly, more microsatellite instability, BRAF mutations, and RAS mutations are being observed in right-sided colon cancer. In our study, we only focused on colon cancers, that is right-side colon cancer and left-side colon cancers. Therefore, our aim was to compare the clinical pathological quantity and surgical outcome between the treatment of right colon cancer and left-sided colon cancer treated in the Department of Gastrointestinal Surgery in the years 2018-2023. We performed a retrospective analysis of 189 patients with the median age of 69 years treated with surgical methods for colon cancer. Right-side colon cancer constitutes of 48.50% of all cases, while left-side colon cancer of 51.85% of cases. We observed the growing number of both RCC and LCC from 14 in 2018 to 75 in 2023. The patients with RCC tend to be older compared to the patients with LCC, with the median age of 70 years in RCC group and 68 years in LCC group. We observed that symptoms between right-sided colon cancer and left-sided colon cancer are similar, with the only difference being the higher occurrence of anemia in patients with RCC. Most of our patients were assessed to the third group of American Society of Anesthesiologists scale. This assessment was comparable between both groups. We have also compared the surgical characteristics. The most common surgical treatment in right-side colon cancer was right colectomy, hemicolectomy, while in LCC it was sigmoidectomy. The complications rate as well as fertility and mortality was comparable between both groups. We performed a logistic regression analysis with listed variables to find the predictive factors for postoperative complications in the treatment of colon cancers. In the univariate model, only the admission mode and scope of surgical and intent of surgical treatment proved to be a significant factor impacting the occurrence of postoperative complications. Therefore, we performed a multivariate model in which only the emergency admission mode proved to be an independent significant factor for postoperative complications. Most common localization in RCC patients was ascending colon, while sigmoid colon was the most common localization in LCC patients. More mucinous tumors occurred in RCC compared to the LCC. Nonetheless, the American Joint Committee on Cancer Staging was similar between both groups. In addition, more lymph nodes were isolated in RCC patients with median 17 compared to the 13 in LCC patients. And here we have a graphical presentation of this data. More patients in LCC group required adjuvant chemotherapy compared to the RCC patients. In addition, more FOLFOX treatment were used in RCC patients. The median follow-up time was similar between both groups with 11 months in RCC patients and 10.75 months in LCC patients. The recurrence rate as well as 1 year survival was similar between both groups. And here we present Kaplan-Meier curves with overall survival between RCC and LCC patients. We also performed a Cox proportional hazard regression model to find independent predictive factors for overall survival. In univariate model, only the scope of surgical treatment as well as AGCC staging proved to be a significant factor impacting the overall survival. Therefore, we performed multivariate model with these variables, in which the palliative resection as well as stage 3 and 4 proved to be a significant factor impacting the overall mortality. And here we present Kaplan-Meier curves with overall mortality in AGC staging and scope of surgical treatment. To conclude, our study confirms the growing number of colon cancer in our country. In addition, patients with RCC tend to be older compared to the patients with LCC. More mucinous tumors occurred in RCC patients compared to the LCC. The frequency of postoperative complications does not differ between both groups, but the emergency hospital admission mode can be a significant factor, predictive factor for occurrence of postoperative complications. What is most important, there are no difference between RCC and LCC patients in overall survival. In addition, the AGC staging and scope of surgical treatment can be predictive factors for overall survival. Thank you very much. Do you have any questions?
Thank you very much. Are there any questions?
My question about your presentation is about what is new in your opinion in this analysis.
What is new, especially new, is our predictive factors for postoperative complications as well for overall mortality in Poland, in Polish population, because we only found these factors impacting the overall survival in foreign populations. In addition, what is new, I think that is new, the predictive factors are new.
Yes, I agree with you, because in how publications we can read about complication in United States, in Europe, in Asia, but for many years there wasn't this about this publication in Polish population. Thank you.
Thank you very much.
So I had the same question, so no question, but one remark, the same as earlier, colon cancer. Cancer means the malignant neoplasm every. So your study concerns not lymphoma.
Yes, actually, we...
Be precise.
Actually, we wanted to include all of the colon cancers, but unfortunately in our department, there were only colon carcinomas.
But remember about it in the future. And the second remark, mucinous tumors should be mucinous adenocarcinoma, because this is a type of adenocarcinoma.
Yes, but actually in some of the publications it was presented like this, like mucinous tumors.
I am pathologist, so.
I have an idea. Sorry, I have an idea to conduct this analysis in a few departments of oncology in other students' university. So I think that this units of this university dependent of the hospital, dependent of the surgeons, and so on. It may be very interesting for our knowledge, because colon cancer is one of the most popular cancers, and a lot of hospitals treat them by surgery, and it may be very, very interesting. Thank you very much.
Thank you very much.
I have one question because you in the abstract you said that the 1 year overall survival is similar between both groups. So what do you think? How long should we observe patient after surgery to recognize potential differences in survival, and do you expect of it?
Okay, so the most common used overall survival is 5-year survival. Unfortunately, most of our patients were treated in 2023. So it was lack of follow-up data because the follow-up period was very short. But recent studies suggest that there are two opinions about the overall survival between those groups. One side said that there are significant differences with RCC being a higher overall survival, 5-year survival compared with RCC. Nonetheless, not all of the studies found that factor. So our study mostly with I didn't show it here, but we also calculate the estimated 5 years survival for our patients. It also was similar between both groups. So our study is more on the second side with no significant differences between LCC and RCC in overall survival.
Thank you very much for your work. And I think we can move to the next one, which is the influence of selected stimulators on leukemic cells from children with acute leukemia.
Esteemed jury, ladies and gentlemen, I'm Anna Kozub, the leader of the student project conducted in Department of Microbiology and Immunology here in Medical University of Silesia in Katowice. And today I would like to present you the preliminary results of our study conducted since November together with my colleagues Rafał and Mikołaj on the influence of selected stimulators on leukemic cells from children with acute leukemia. To begin with, according to some medical data, leukemia is the most common malignancy in children, and the illness is most often diagnosed during the first years of children's life. Moreover, the blood examinations, especially bone marrow biopsy, became a gold standard in the diagnostics of this illness, and the majority of the of leukemia origins is BCP, so B-cell precursor lymphoblasts. And then, what are the mitogens? The mitogens are the particles or proteins that trigger the rate of cell divisions, and they act upon mainly G1 phase of cell cycle. For instance, for T lymphocytes, such mitogens could be phytohemagglutinins, and for B lymphocytes, for example, lipopolysaccharide. And now the aim of our study, it was just to assess the production of selected cytokines from the groups of interleukins, growth factor, TNF, in the bone marrow blasts from 3 types of leukemia: acute myeloid leukemia, T-cell acute lymphoblastic leukemia, and the most common B-cell precursor acute lymphoblastic leukemia, after this 24-hour stimulation by some mitogens showed here, so phytohemagglutinins, PMA together with ionophore, and lipopolysaccharide. And now let's move on to the methodology of our study. Well, after collecting all necessary agreements and approvals, it took us about a month of theoretical and also lab preparation to be ready to work in a lab by ourselves. And I should imply here that the work cycle for each blood sample contained 1 week, and for the 3 days in lab and 4 days for conclusions and estimation of the results. And now, during the first day, we had to extract the lymphocytes from the blood samples, and then we created the cell culture in such bottles showed here. Then, after 48 hours, we had to change the medium and also prepare the mitogens in a proper concentrations, also written there, according to available literature. And also we had to add them, and they stayed for 24 hours in 37 Celsius degrees just for incubation. Then after those incubation, we have to decant them into Eppendorf test tubes, and then they had to be frozen. The time ranged from 1 week to 3 weeks, because when we collected a part of the tubes, we could then perform this bioplex examination, which costs a lot, so it was only available to perform about once in a month. And then let's move on to the obtained results of the study. I will try to highlight the main statistically significant trends. And as for the statistics, we firstly, after we checked whether we have like the normality proportion of the results, we used this ANOVA test and then the Fisher exact test. So for the first cytokines, so we have now here growth factors. We can see that the highest concentrations were measured in AML cultures, and especially for this GM-CSF, a lot of results are statistically significant. Then we have hemokines, so this microfarc-induced protein 1b and interleukin-8. For them, we can see that they were significantly induced by all stimulators in this BCP ALL all samples. However, we can see also that the scatter of results is huge also in other types of leukemia, however, without the statistic significance. Then we have TNF-alpha and interleukin-4. So for interleukin-4, it was also AML and PHA and PMAI that was statistically significantly induced. And for TNF-alpha, it was PMAI and LPS. Then we have interleukin-1 beta and IP10 protein. So for this 1 beta interleukin, this was without statistic significance. However, it was, I think, close to it because it was 0.06 and 0.07 for PHA and PMII. And for IP10 protein, it was in TLL groups, also those two mitogens showed. And also we have two other. However, without the statistic significance, we can say the scatter of results in this case and also in case of other growth factors written in abstract. So we have to conclude that they are still without the statistic significance. However, we conduct this experiment constantly, so maybe in the future some patterns will be showed. So moving on to the discussions. Let me say something about the limitations of our study, because our main limitation was definitely the cost, because it costs a lot, about 20,000 zlotys to perform one bioplex examination. Moreover, those are the preliminary results, only 28 cell lines with 3 repetitions performed, and also the time of frozen those test tubes also could play a role. However, we hope that not a very big indication. Then, however, we can say that we achieved our main goal because we can see some patterns of production of cytokines, and it's also with some of this is with statistic significance, so we can conclude, and those could be the conclusions of our study. And maybe as for the usefulness of our study for oncohematology, we can say that there are also some free studies. However, they didn't use mitogens at all. They could conduct it just on these blood samples from children. And we can say that there are some cytokines like interleukin-2, 4, TNF-alpha that are significantly induced in the samples from children with leukemia. And moving to the end, we should imply here that the cytokines, such experiments are being prepared since 1990s. However, as I said, there are not some studies with the use of mitogens, so we are the first, or maybe one of the first ones at all, just to prepare it, especially on this leukemic cells, because as you can see in other branches of medicine, sometimes, especially the pro-inflammatory cytokines are being examined and not for children leukemic cells at all. Thank you very much. I wanted also to say that all background these blood photos were taken also by us using our microscope. And thank you very much once more for the attention. Those are us during work in a lab. Thank you.
Thank you very much for your work. And we can move on to the discussion.
Beautiful presentation.
Thank you very much.
Very interesting work. Very important conclusion. So only one question. What is your contribution?
Well, as I said, I'm the leader, and I was the one to think of such kind of the study, because it was during one of our
scientific group meetings in the department that I got the book from the conference on flavons that our professor took part. And I noticed that they tried to examine the flavons. So, for example, PHA, PMA plus I, on other substances. And as I know that our second tutor works in a lab in the center of Zabrze when they diagnose children leukemias. So I thought, why not to combine it, try to make some experiment that will combine the flavons, which are common in our department, and also with the material, which is quite available also. And also, as I checked in PubMed and in Embase, that there are not such studies, so why not to conduct? So maybe in the future it could be useful for other examinations on cytokine stores, on the tumor necrosis. It was just. However, the problem was just to find other people interested in lab, because like we work each week about 20 hours since November, and we continue still. So I think like we are very highly motivated, and I think we established quite friendship, because like we spend there a lot of times.
Thank you very much. Are there any other questions? If not, we can move to the next one. Thank you very much. Okay, so the next presentation is assessment of genetic predisposition in patients with neuroendocrine pancreatic tumors.
Good afternoon, ladies and gentlemen. Today I have the pleasure to present two of my original works on endocrine oncology, mostly. The first one will be about the assessment of genetic predispositions in patients with neuroendocrine pancreatic tumors that were treated on the course of more than 30 years in the National Institute of Oncology in Gliwice. At first, some basics about the neuroendocrine tumors in general. I think what is important here is that the neuroendocrine cells that form the neuroendocrine tumors are scattered throughout the whole body, and they can either be isolated, like for example in the bronchi or in the thymus, or in the whole gastrointestinal tract, or they can also be grouped as it is in the pancreas. And I think it's quite obvious, but I've highlighted that on your right, that today we'll only focus on the pancreas. Other important things is that the neuroendocrine tumors are generally divided into functioning and non-functioning. And here, that the tumor is functioning means that it secretes an excess of hormones, so we can detect that. And that excess of hormones can later result in some other symptoms that probably would be the first that the patient would present with. And non-functioning would be in the cases that the excess of hormones secreted by the tumor is non-present, or it's small enough not to be noticed by the patient and by the clinician too. And the last thing from the basics is that the etiology of the neuroendocrine tumors remains unknown. However, we know that they can be a part of MEN1 syndrome, which stands for multiple endocrine neoplasia type 1, and VHL syndrome, which stands for von Hippel-Lindau syndrome. Or they can be spontaneous lesions, but today we'll only focus on the genetic ones, the genetically inherited ones. So here's a quick overview of MEN1 syndrome. On your right-hand side, you can see the components of the multiple endocrine neoplasia type 1 syndrome. And today we will focus on the pancreatic tumors, but I would like to point out that the other components of the syndrome are really essential too. And later I will come back to it, why they are so essential. And on the left, we have the sequence of events that leads to the tumor formation in MEN1 syndrome. Maybe I'll go through this really quick. So at first we have the germline mutation of MEN1 gene, and it happens that this gene is a tumor suppressor gene. Then we have the cells, neuroendocrine cells that are working without the appropriate copies of the gene. So that after that, it results in the lack of functional menin protein, which is the product of a MEN1 gene.
And it is worth mentioning that the menin protein is also a tumor suppressor protein. So like the effector of MEN1 gene. And in the end, it leads to the formation of endocrine tumors in different organs. And here's the similar overview of von Hippel-Lindau syndrome. On the right, there are all components, possible components of von Hippel-Lindau syndrome, but once again, we'll only focus on the pancreatic tumors today. And the sequence of events is maybe not the same, but similar. So the germline mutation of the VHL gene occurs, and it is worth mentioning that the VHL gene is also a tumor-suppressing gene located on the third chromosome. It results in the abnormalities in the VHL protein that is a main product of the expression of the VHL gene. And there's a functional loss of VHL protein, which is also a protein that suppresses the tumors from forming. And it is done in the way that the VHL protein, its role is to make the HIF, so hypoxia-inducible factor degradation possible. So without the functional VHL protein, we have the accumulation of HIF, so hypoxia-inducible factor, and that in result of that, there's an increase in expression and then accumulation of other proteomorogenic compounds. For example, a VEGF, so a vascular endothelial growth factor, or PDGF, so platelet-derived growth factor. And that these factors contribute to the fact that these patients present tumors. So my aim was not only to assess the genetic predisposition of the patients with MEN1 and VHL syndrome in the National Institute of Oncology in Katowice, but it was also to take something out of this result and to formulate a thought, what we should do and how should this influence our management of these patients. So what should we pay attention to in these patients? Here are the materials and methods. I performed a retrospective analysis of 200 patients that throughout the years, because you can see that the years are from 1994 to 2023, so there were quite a lot of patients during that time. I performed a retrospective analysis of 200 patients, and I included 134 of them to be included in the study. And out of the 134 patients, we were able to perform the genetic testing for both MEN1 and VHL syndromes in the cases of 114, which makes up for 85%. And out of these 114 patients, patients that were MEN1 positive, so we detected a MEN1 gene mutation, it was 14 patients, so almost 13, more than 12% of these. And the patients with VHL mutation detected made up for with something percent of the patients. Here we have the graphic presentation of the results of both syndromes, and I would like you to pay attention mostly to MEN1 because it will be significant on the next slide. And here I would like to mention the guidelines by ASCO, so American Society of Clinical Oncology, that the genetic testing for any genetic predisposition that is potentially existent in these patients should be always performed if in the previous data, in the previous research, the genetic predisposition was present in 10% of the cases or more. And so here we can clearly say that 12% is more than 10%. So I think that the conclusion out of it would be that we should first listen to the ASCO guidelines, but for people that are not endocrinologists or oncologists, I think it would mean that we should really pay attention to the patients presenting to our clinic with the symptoms or possible symptoms and components of the MEN1 syndrome, because it's really important to know the whole, all the components of the syndrome.
I'm sorry, but you are run out of time, so please go to the conclusions.
Okay. So I would like to say that the presented analysis clearly indicates that the possibility of the existing predisposition, genetic predisposition, has not been taken into account sufficiently, as for now, at least. And it's really important because, as for example, in the VHL syndrome, we have the targeted drugs that can be used to at least to try to cure these patients. Thank you.
Thank you very much. Let's move to the discussion. Are there any questions?
I think that genetic testing will be more important significance in the future.
Yes, I think so. If only the possibilities of the laboratories are enough, efficient enough to, pursue the need for genetic testing, I think it would be really important because it allows us to, divide patients into groups of high risk, low risk, or intermediate risk, and then proceed with further diagnosis. Not only diagnosis, but further diagnosis and further follow-up. Because, for example, if the patient is MEN1 mutation positive, we should really pay attention to the next and long-term follow-up because they can present with primary hyperparathyroidism or pituitary tumors, as well as other compounds of this syndrome. So I think it's really important, and it is the future. Thank you.
My question is about patients who are suspected or diagnosis of NETs. How big is the group of suspected and why you included in your study so suspected? Those patients are without diagnosis, or I can't understand why this group was suspected at the diagnosis. And my conclusion is that when we have diagnosis of NET and we treat them, we always, in all patients in our clinic, make genetic tests of both genetic disease. Thank you.
Okay, so to answer your question, the last part first, I think it's really nice because it really gives us an insight on the possible outcomes of the patients and the prognosis and the needed follow-up, and even on the possible morphology of the tumor because it is different. It is sometimes different in MEN1 positive or MEN1 negative patients. And coming back to the first question, some of these patients were included into the study because it wasn't like only a mild suspicion; it was a strong suspicion of the pancreatic neuroendocrine tumor existing, because they were assessed on the basis of the computer tomography, and they were assessed by some means of nuclear medicine. But they were not in a quite good condition, so they were not able to perform the endoscopic ultrasound that is now the gold standard in not only the diagnosis but also collecting samples to be histopathologically tested and checked afterwards. So these were the patients that were included because there was a strong suspicion that the PNET is present. However, we are not able to provide maybe the clear histopathological conclusion in those cases of these patients. So, for example, they were not fit for an endoscopy with an ultrasound or maybe some of them there was the endoscopic ultrasound performed on them in their cases, but the final result of the histopathological testing was inconclusive. So we weren't 100% sure. That's why I included those patients, even though the last final result was inconclusive.
And how big was
I had similar question.
Excuse me?
Excuse me. How big was the group with suspected neoplasm?
I think there were about 20-something patients.
Okay, thank you.
Thank you.
Thank you very much for your work. And we can move to the next one. So the next presentation is differentiated thyroid cancer in pregnancy, a retrospective analysis of newly diagnosed patients.
So maybe I won't repeat the title. So let's begin. And now a short overview of the thyroid cancer. Here we have the short overview of what comprises, what DTC comprises, and DTC stands for differentiated thyroid cancer, as we see. And so we can see that it's in most of the cases, almost 90% is the papillary thyroid carcinoma, so PTC, and it was the most prevalent one in the group I performed the study on. It's also the follicular thyroid carcinoma and other thyroid cancers. For example, oncocytic thyroid carcinoma, which is quite rare, but it occurs. It is important to know that this is a malignant tumor originating from the follicular cells of the thyroid, and only patients with cancer, with the malignant lesions were included in the study. And then something about the differentiated, it says that the cancer cells do not differ much from the normal thyroid cells. And here we have the risk factors. Maybe it's not very important here. Here we can take a look at the recommendations by the American Thyroid Association and the Polish Society of Endocrinology. These include the fine needle aspiration biopsy and the results of it with using the Bethesda system for reporting thyroid cytopathology. And I know it's a lot of text, but I think we can conclude from both of these that they say that in pregnant women, if we consider surgery, it should be done before the 24th or 26th weeks of gestation. And we generally think of surgery in Bethesda 5 and Bethesda 6 nodules. I will explain it in a minute. And so the most prevalent one, as I said, was the papillary thyroid cancer, and it makes up of almost 90% of all DTCs. And what is important to see here is that there's very favorable prognosis. So the 10-year overall survival is almost 95%. And now we have very new and modern ways of diagnosing and of treating this cancer. And it will be important for my conclusion later. And another significant statistic is that more than 50% of newly diagnosed papillary thyroid cancers every year were microcarcinomas, so they were less than a centimeter in the diameter. And it's really important for the further prognosis of the course of the disease in those patients. So the aim was to analyze the patients with Bethesda 5 and Bethesda 6 thyroid nodules that were detected and followed during the pregnancy. I will explain the Bethesda reporting system in a minute. So I performed a retrospective analysis of 96 patients that were diagnosed with suspicious thyroid nodules at that moment. And the group of 64 women were included at the mean age of 30.9 years old. The nodules that were included, so the patients with nodules that were included in the study had to be diagnosed during pregnancy and classified either as a category 5 by Bethesda, which means suspicious for malignancy, or category 6, so malignant. And they were confirmed but verified by 2 independent pathologists. It's important because it's also the part of the guidelines, either by the ATA and by Polish Society of Endocrinology. Here we have the category. And so just to explain the Bethesda reporting system, from non-diagnostic and at stage 1, at number 1, and then the suspicious for malignancy and malignant and 5 and 6. And something about the methods too. So the patients were followed by a neck ultrasonography every 2-3 months until the surgery. And the median follow-up from the diagnosis to surgery or to the last follow-up, because some of the patients have not been operated on yet, was 10 months. And here you have the amount of percent of Bethesda 5 and Bethesda 6 patients. And here are the results in a graph, presented in a graphic way. And we can clearly see that even though that in the majority, because it's 73% of patients, the diagnosis was made before the 24th week of gestation, almost 88% of the patients decided to be operated on after the pregnancy. We have no data about the 10 of them because they have not been already operated on, and only 2.7% of patients had to be operated on before the delivery. So it will be really important for the conclusion. And here's some data about the thyroid nodules. So more than 50% is worth mentioning connected to what I said before. So more than 50% of the patients were diagnosed with microcarcinomas, so the nodules and confirmed carcinomas that were smaller than 1 centimeter in diameter. It's very important. And here is the dynamics of the nodules in those patients. So the number of nodules that were growing during the study was only 13.6%. So 86, or even more than 86% of the patients were stable. The nodules in them were stable. So it's also very important for the conclusion. And so the conclusion is that the watchful waiting strategy, which is also mentioned by the American Thyroid Association and the Polish Society of Endocrinology, is really a safe option for the patients diagnosed with papillary thyroid carcinoma, or even the suspicion, because we need to mention the Bethesda 5 category. However, the careful monitoring, as we did, so the regular follow-up, ultrasound follow-up, should be considered to choose the best time for surgery, because those patients, the 2.7% of patients that were operated on during pregnancy, were diagnosed at some point of neck ultrasonography, were diagnosed with lymph nodes metastasis. So that was the moment, a signal for us to get them referred to a different facility when they can be operated on with the assistance of obstetricians, so they can be well cared for. But we have to remember that the thyroid cancer in general, but especially in a pregnant woman, it's a very stressful situation. And we have to remember that the possible complications of the surgery during the pregnancy are like double, 2 times higher than the usual ones when the patient is not pregnant. So I think that it's quite important, and it's a kind of a practical advice that, of course, we have to be cautious, but it is a strategy worth introducing, that the surveillance and regular follow-up, and sometimes waiting to after the postpartum period and even sometimes later is crucial, and it would be really useful in the use of with these patients with papillary thyroid carcinoma. Thank you.
Thank you very much. Let's move to the discussion. Are there any questions? No questions? So I will ask, what was your contribution to this work?
To this one or to the previous one?
To this one.
I made the whole database of the patients, and I performed some of the ultrasound examinations, of course, under a supervision of one of the doctors, myself. And then I put it together into the database, and I made the presentation myself. So basically most of the work, I think.
Thank you very much.
Thank
Are
you.
there any other questions? Okay, if not, thank you very much. And we can move to the next one. It's epidemiological and histopathological insights into brain tumors from advanced biopsy techniques.
Welcome, dear audience and esteemed jury, to my presentation today about the epidemiological and histopathological insights into brain tumors from advanced biopsy techniques. So brain tumors are a complex neoplasm derived from various cell types within the CNS, present a significant diagnostic therapeutic challenge. The WHO classification of tumors, first released in 1979 and last updated in 2021, serves as a cornerstone for categorizing these tumors and posing diagnoses today. Our classification, the classification system integrates histopathological and molecular characteristics to refine diagnostic accuracy, guide therapeutic decisions, and improve prognostic assessments. So the aim of our study was to determine the epidemiological aspects like age distribution, sex, and the location of the tumors to give us a deeper understanding of the tumor prevalences in our cohort and compare them with global statistics found by the WHO. So we have a retrospective cohort study which was performed using patient data from January 2011 to August 2003, analyzing 112 patients who underwent brain biopsies employing the WHO brain tumor classification. We only used patients that had full data or a follow-up. And out of those, we also created then 10 groups based on the classification of the location of the lesions to distinguish them by that. And we also analyzed the occurrence rate by sex and age. And the study also evaluates the success of these diagnostic yields and correlations with clinical outcomes, emphasizing the histopathological and molecular diagnosis. So as I said before, 112 patients, 58 of them male, 54 female, age ranged from 18 to 82 years old, averaging around 58 years. And our primary affected group was 60 to 69 years old, contributing 31% of the whole patient group. Here we can see the age distribution, that more than half of our patients were over the age of 60, but generally the spread is mostly featured around 60 to 69. And based on the location of the tumors, as mentioned before, we have 10 groups. So we have the frontal lobe, temporal lobe, parietal, occipital, the brainstem, cerebellum, the deep hemisphere, the corpus callosum, insula, and the ventricula. And here we can immediately notice on this graph, very visible, that the deep hemisphere poses the greatest share of patients, with the frontal lobe following up closely, and the temporal lobe and the parietal lobe, posing the 4 main ones that we have. Here we can also notice that the glioblastoma on the right-hand side is the #1 occurring diagnosis with 27%. And then the second one being the diffuse large B-cell lymphoma with 17%. But also the third biggest group in our statistic here are just patients with no malignant features, being 12.5% of the whole share of patients. And our results here show that, first of all, the most affected brain regions were the deep hemisphere with 24% of occurrence, then the frontal lobe with 21%, and then followed up by the temporal lobe with 16%. The most common diagnoses include the glioblastoma with 26% and diffuse large B-cell lymphoma. So in general, all of these align with the global statistics and also statistics given to us by the WHO, that the locations and the most common diagnoses are in alignment and don't stand out at our clinic as well, and that also the age groups are in the same brackets. So in general, also the study highlighted a high success rate with diagnostic biopsies and minimal complications for the patients. So we conclude that the research aligns with global epidemiological data, enhancing the existing knowledge we already have on the basis of brain tumor histopathology and the epidemiology of it. Thank you all for your attention.
Thank you very much. Are there any questions?
I have a questions about data of your patients. These types of histopathology are typical. What's new was the idea of your work? Only tourism in your clinic? What was the types and epidemiology and histopathology types, or something else?
Well, the main aim was to check at our clinic, which is the local clinic we are in right now, to see if our patients have the same occurrence rate of diagnosis and age group, or if there is something that stands out here, something that might be relevant, or to just confirm what's already known and just enhance our knowledge in that and strengthen the reliance we have on these global statistics, just confirming that it's the same case here in Katowice as well.
Okay, thank you.
Thank you very much for your work, and we can move to the last presentation for today. It's the elemental analysis of laryngeal cancer tissue using synchrotron beam light preliminary report.
Ladies and gentlemen, my name is Antoni Wołoszyn. I am a fifth-year medical student at the Medical University of Silesia, and I proudly represent the Student Society of Laryngology under the supervision of PhD Jarosław Paluch. At the beginning of my presentation, I would like to pay attention about what kind of the knowledges medicine is based on. At the basic sciences, observational and applied sciences, but in my presentation, I would like to pay special attention to the experimental one, because our study was an experiment. The main aim of our study was to understand the mechanics of the cancer at the macro scale. We need to have a good understanding of it at the nanoscale. To explore our idea, we turn to the advanced techniques such as the synchrotron. But what exactly is it? It consists of two main parts. What is the linear accelerator, where the electrons are accelerated almost to the speed of light and then injected to the accumulation ring, where due to the curvature of the electron's path, electrons emit photons, and this photon beam light, we can use in the research stations arranged around the ring in almost every field of science. For example, also in the medicine and in oncology. Our study consists of several stages, during which we examined 8 pathological samples of cancer tissues and 4 normal samples in the Synchrotron Radiation Center Solaris of the Jagiellonian University in Krakow. The first step, that was the pilot experiment, and the main premise was to use exactly the scanning transmission X-ray microscopy to examine the human brain tissue. The most important thing and the most important problem of the study was the preparation of the samples, because we need to put they to the special media, but the results was very promising, because we found the characteristic energy edge for the nitrogen. So that showed us that this methodology of preparation did not disturb the tissue, and here is the collaboration between the nitrogen presence and the glia present in samples. The next step was to examine the squamous cell carcinoma of the larynx, samples of this tumor. So we compared it also with the normal healthy human tissues samples. So we did also the transmission electron microscopy images, as you can see at this slide. But the main point of study was to identify the selected elements from the carcinome such as oxygen, potassium, and carbon. The most important finding was the revaluation of the iron ions, because that was the idea that the iron overvaluation is an important part in their mechanics of the, if their mechanism, and also probably is the key to the key of the component of the metastasis, also of the angiogenesis and proliferation of the cancer cells. The last part of our study was again to try using the scanning transmission X-ray microscopy to examine the human brain tissue and again laryngeal cancer tissue. We did also the inspection under the light microscope, but the most important part of the study was to examine the edges for the oxygen, nitrogen. But what was the most important and interesting finding from this part of study, that the iron ions were not stated in samples. So probably we found some breach in the mechanism in mechanism of cancers, because here is a breach probably with the Warburg effect, because some cancers change their metabolism from oxidative to non-oxidative. So they don't use iron to oxidation processes. Our study was just a preliminary report. That was maybe not just, but that was the preliminary report, an experiment in the oncology. So maybe probably we are close to explore new marker of cancers, which is the absence of irons in samples. The next stage of our study is the analysis of our previous results in the synchrotron interest. At the end of my presentation, I would like to show you also like the short reel about our last visit from the Solaris Center. So would you start? Thank you for attention. Thank you for your attention.
Thank you very much for your work. And let's move to the discussion.
Are you going to say to all pathologists in Poland goodbye?
I hope so, but I'm not sure.
So, not nice for me.
But yeah.
Okay, thank you. Are there any other questions? Wait a minute.
That we can't say goodbye to the pathologists because they were also really helpful in our work.
The pathologists are also the part of our team, so that was just.
We also collaborate with Professor from Zabrze.
Yes, with Professor Jasik, so that was just a show.
Okay, thank you very much. And I think that there's one more question from Professor online, yes?
Yes, my question is about choosing laryngeal cancer. Why? Not lung cancer or colon cancer, but laryngeal cancer.
Because our student association is correlated with the laryngology department. Also, our PhD is the specialist in the otolaryngology. So I think he treats mostly the laryngeal cancer. So that was the choice.
Thank you.
Thank you very much. You're free now.
So thank you.
Okay, so all the submitted papers have been presented. We congratulate all the presenting authors and participants of the oncology, nuclear medicine, and radiotherapy session. At this point, I would like to ask the president of the jury for a few words to sum up the session.
Ladies and gentlemen, our afternoon meeting session was very interesting. I hope for everybody. Dear students, you are very nice people, young. I hope you will work still, and we will meet on other scientific meetings. Maybe next year and maybe in another places. So good luck for you, for your future, scientific future. Thank you for my colleagues from jury for questions, and thank you very much for help desk.
Thank you very much for these words. I would like also say thank you to another members of the jury. And we truly appreciate all your valuable comments, accurate observation, and work on the presentation assessment. We would like to cordially invite you to the decoration and closing ceremony of the SIMC 2024, which will be held in the Teatro Rialto on the 17th of May at 6 p.m. And on behalf of the Student Scientific Society, I would like to thank you all for the participation in this session. Thank you very much.
Thank you very much.
Dziękujemy bardzo za uczestnictwo.